Hello everyone. As part of our Initiatives webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Sachs Healthcare Communications, and I am your technical producer. It is my pleasure to welcome you to today's webinar, Processed EEG Monitoring, Use of TIVA in Enhanced Recovery. And now, I'd like to introduce you to Gary Bridges, who is our moderator today. Gary is currently the Chief Nurse Anesthetist at the University of Texas MD Anderson Cancer Center in Houston, Texas. He has served in many capacities for his professional associations, including he is on boards of directors at both the state and national levels. Gary has long been active in nurse anesthesia associations and is a former president of the Texas Association of Nurse Anesthetists, and most recently, he is president of the AANA. He has had extensive success in leading large organizations through healthcare policy development, strategic planning, evidence-based practice, outcome research, and education. And today, we would like to mention a special congratulations to Gary on being awarded his PhD in nursing. Congratulations, Gary, and welcome to our webinar today. I'm so glad to be working with you for this special session, and we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
Yes. Thank you, Emily, for that kind introduction. And I want to thank everyone for joining us for this webinar on processed EEG monitoring, the use of TIVA in enhanced recovery. Speaking on this topic is a leading expert who is at the forefront of this very crucial topic, Dr. T.J. Gann. Dr. Gann is professor and chairman of the Department of Anesthesia at Stony Brook University in New York. Dr. Gann is the founding president of the American Society of Enhanced Recovery and president of the Perioperative Quality Initiative. He is the past president of the Society for Ambulatory Anesthesia and the International Society of Anesthetic Pharmacology. Dr. Gann serves on several editorial boards, including Anesthesia and Analgesia and Perioperative Medicine, to name a few. He's published more than 200 peer-reviewed publications and is considered a world expert on postoperative nausea and vomiting and acute pain. He also has a major interest in enhanced recovery after surgery programs for improving postoperative outcome on surgical patients. So I'd like to start with some disclosures. The speaker has disclosed the following relevant relationships: consultant for Merck, Edwards, Mallinckrodt, Acacia, and Medtronic, as well as part of the Speakers Bureau for Merck, Mallinckrodt, Acacia, and Medtronic. This educational program was funded in part by an unrestricted educational grant provided by Medtronic. I'd like to briefly go over continuing education. Note that, as you can see on the screen, continuing education is available for physicians, as well as nurses, nurse anesthetists, and respiratory therapists. So with that, I would like to turn the presentation over to Dr. T.J. Gann.
Thank you very much, Gary, for that very kind introduction. Good morning or good afternoon, everyone, depending on which part of the country you are listening on this special presentation. I'm very excited today to have the opportunity to talk to you about a topic that I am very passionate about, and I believe that this topic have the great potential in improving the care of the perioperative patients that you and I take care of every day. So without further ado, we will first of all review the learning objectives of this webinar. So really we're trying to accomplish 3 goals. First of all, to describe the objectives of the enhanced recovery strategy. And I know that many of you who are listening are either doing enhanced recovery or maybe in the process of launching an enhanced recovery program at your hospital. So we'll talk about that. And then we will discuss the use of total intravenous anesthesia, or TIVA, within the context of enhanced recovery. And the third would be to assess the value of process EEG when using total intravenous anesthesia. Now, there are a number of different outlines here as I present this webinar, and we talked about the objective enhanced recovery using total intravenous anesthesia, and lastly, to look at the process EEG in enhanced recovery. So let's first of all ask the question of what is enhanced recovery after surgery, commonly referred to as the ERAS program. Well, enhanced recovery after surgery really is a new way to look after perioperative patients. It is a multimodal, traditionally used to be called fast-track recovery approach, and integrated into a clinical pathways. Now, the objective of that is really trying to see how can we return our patient back to normal as soon as possible, potentially having an earlier return of bowel function, shorten hospital length of stay, reduce complications, because that is often the one that delay discharge, and at the same time to see how can we do that in a manner where we come together as a team. Now, it is a paradigm shift for the perioperative care environment, because this is not how we traditionally do things. So we have to re-examine how do we traditionally take care of patients, and how can we, with this new model, with the new evidence, can we improve that perioperative care? And that is really what enhanced recovery is about. Now, there are many elements of enhanced recovery, and I put it up here, some of the important elements that is divided into preoperative at the top there you can see, and intraoperative elements here, and then post-operative elements. But there are really a few what I consider is the sort of must-do elements for enhanced recovery. For example, I think patient education is really key, because if the patient knows what he or she are expected to go through during surgery, the patient will be much more involved in his or her own recovery process. So patient education is really one of the key elements. Now, within the perioperative period, there are important elements such as pain management. Again, if you can do pain management well, often you can have a significant impact on patient recovery. Also, fluid management is something that we as anesthesiologists or anesthesia care provider really should be focusing on. Prevention of nausea and vomiting, for example, and also giving appropriate level of anesthetic. Again, we don't want the patient to be kept too deep, neither do we want the patient to be kept too light. So that is important to monitor patients so that they get the right appropriate level of anesthetic. And then post-operatively is really trying to encourage a patient. How do I get a patient start to eat and drink earlier? How do I get a patient to start mobilizing earlier? Because if you can achieve both, you have a very high success rate of getting the patient out of hospital. And that includes getting the tubes, catheters, drains out of the patient so they can be much more mobilized post-operatively. And important thing is also audit your data, because unless you have a good data audit, it's difficult to know how you can improve or how much progress you made on enhanced recovery. So one of the important things is post-operative complications. Now, we as anesthesia care providers, sometimes we don't realize that what we do in the operating room have a significant impact in whether the patient develops post-operative complications. Now, it is crucially important. If you can avoid a complication post-operatively, you have a huge potential in reducing perioperative costs. Now, this study shows that in patients who do not have complication post-operatively, their cost is typically pretty standard. As you can see here, about $5,000 for that hospital stay. Now, once the patient develops complications, whether it's infectious or cardiovascular, and if you look at respiratory, huge cost escalation if you develop respiratory complications, 10 times more than without the respiratory complications. But if you develop a complication, that is where that cost of hospital admission goes up substantially. And it's estimated that the average cost of a complication is about more than $10,000. So you can see that how important that is. So first of all, let me just share with you the enhanced recovery results that I was part of as the enhanced recovery team when I was at Duke University a number of years ago now, that looked at in colorectal patients. If you have a successful enhanced recovery program, what does the result look like? Well, so we took a group of patients undergoing colorectal surgery. We then implemented enhanced recovery protocol. We then collect data before and after the launch of enhanced recovery protocol. Now, as you can see that, this slide shows you the length of stay. On the y-axis, the number of days when the patients stay in the hospital, and on the x-axis are all patients, all comers, and then divided into whether they are open colectomies or colectomies done via the laparoscopic approach. So you can see that in all colorectal patients with an enhanced recovery protocol, the hospital length of stay is reduced by more than 2 days on average. In the open colectomy approach, is more than 2 days. Even in the laparoscopic approach, we were still able to show a reduction in length of stay of about 2 days. So that is substantial. If you, for average patient, you can reduce the length of stay by 2 days, you can have a significant savings from the shorter hospital length of stay. What about some of the other advantages of enhanced recovery? So what do we find before and after enhanced recovery? Well, we found that we give less crystalloid and potentially getting less edema. We had a lower estimated blood loss in the patient with enhanced recovery. And if you look at the day when the patient resumed oral regimen, so before enhanced recovery, an average patient takes less than 2 days to start drinking. Now, once we launch enhanced recovery, patients start to drink at the end of the day of surgery. We also found that enhanced recovery protocol, we were able to have patients start eating solid food about a day earlier. Urinary tract infection was lower because we removed the urinary catheter earlier. We take the NG tube out earlier. And contrary to what some people are concerned about, maybe you discharge this patient too early and therefore the patient may come back. Therefore, readmission rate may be higher. But interestingly, we found just the opposite. Our readmission rate actually was half compared to before enhanced recovery. So you can see the advantage of enhanced recovery in the recovery of these patients. If you look at pain score, for example, average pain score, highest pain score was significantly reduced. The amount of opioid that was used with the multimodal analgesia approach following an enhanced recovery protocol was significantly reduced. And if you look at the median morphine use is about 4 times less than before enhanced recovery protocol. Now, all these things are really good news for patients. Now, not only that, what we found is that we also achieved significant cost savings for the hospital. And this is where if you present this data to the C-suites, to the CEO, CO of the hospital, they will be delighted to see this data, because what we showed is that on average, 50% of the time, we were able to reduce the cost of that patient, average patient, by about $2,000. And about 25-30% of the time, that cost saving is over $4,000. Imagine that if you are doing many of these procedures in your hospital, and each patient, you can save between $2,000 to $4,000 per patient. That amount of cost saving adds up substantially. So those are really the advantages and what you would expect to see when you have a successful enhanced recovery protocol. Now, we are not the only group that shows this excellent results from enhanced recovery. There have been many studies, and I just want to share with you, this is a meta-analysis looking at the various enhanced recovery protocol, looking at morbidity, readmission rate, surgical site infection. All of them showed that on average, enhanced recovery protocol was associated with just over 2.5 days reduction in hospital length of stay, and also a 33% reduction in morbidity risk. So these are some of the very tangible advantages of a successful enhanced recovery protocol. And as I mentioned earlier, cost reduction per patient in this meta-analysis show that it range anywhere between $174 per patient to over $7,000 per patient. So substantial. And there are also other data suggest that patients do better following enhanced recovery. And contrary to the popular belief that the patient may come back to the hospital readmitted, that is not the case. So clearly, enhanced recovery really achieves significant improvement in outcome. Now, within the context of enhanced recovery, how can we tailor our anesthetic so that we can provide an anesthetic which will potentially help with the enhanced recovery process? So I want to talk to you a little bit about the approach of total intravenous anesthesia, because I think that in this country, we do not use TIVA as one of the main anesthetic techniques. Perhaps some people do, but in general, in the US, TIVA is less widely practiced compared to, for example, countries in Europe and other parts of the world. But there are a number of very tangible benefits of total intravenous anesthesia. And this just show you some of the advantages, right? We don't need to worry about the impact on the environment of the gases and inhalational agent because you don't need a scavenging system with an intravenous anesthesia. Propofol, which is really the main drug for the use in total intravenous anesthesia, is a very potent antiemetic. In fact, studies have shown that if you were to give Propofol total intravenous anesthetic throughout the procedure, is equivalent to giving an antiemetic. So it has substantial antiemetic properties, and it also improves the quality of emergence, the quality of early post-operative recovery. Patients who are undergoing propofol anesthetic often have been shown to be more satisfied. They have less post-operative pain. They are much more clear-headed. They can then be discharged from the recovery, especially for day surgery earlier. And again, now propofol is generic, and therefore cost is no longer an issue. So there are many advantages of using TIVA as part of the enhanced recovery protocol. Now, many society recommendations that again encourage the use of total intravenous anesthesia, and this is just an example of the Enhanced ERA Society recommending that in a number of procedures, TIVA is a very good technique for improving patient outcome. Now, there are also potentially some concerns that people have in terms of what is the impact of anesthetic in increasing the risk of cancer recurrence. And in fact, in this context, this study show over 5,000 patients that really there is no difference whether you use TIVA or inhalation anesthetic in terms of 5-year recurrence rate of disease-free survival. So from that aspect, what we can be assured is that it does not really increase the risk of cancer recurrence. All right, so let's take a look at what about in elderly populations. Again, we are increasingly in an aging population, so we treat more and more elderly population. And one of the main concern of elderly population undergoing surgery, and in particular during the recovery process, is this cognitive dysfunction or postoperative delirium, because this is really an important a challenge for us to how can we reduce that incident. Because post-op delirium, if you, depending on the type of surgery, there has been shown to be at an incidence of around even up to 40, 50, 60%, depending on the type of surgery, depending on the age of the patients. The higher the incidence, the more elderly the patients are. And so you can see that here it still shows you the incidence of between inhalational agent anesthetic versus total intravenous anesthesia. And there is fairly substantial evidence that TIVA may potentially reduce the risk of or incidence of post-operative cognitive dysfunction. So there's another advantage of using TIVA. All right, it's about what about some other reason why do we want to measure the anesthetic effects of the brain? Well, interestingly, you will see that the traditional models that we use is to look at what about the patient's hemodynamics, right? Using blood pressure or heart rate to really guide us for our anesthetic. But, you know, hemodynamic is not a very precise values and not very precise parameters for us to gauge our dose of anesthetic. And also patients are different. Some patients has different pharmacokinetics, some patients have different metabolic rates, and therefore they metabolize drug very differently, in particular things like opioids and benzodiazepines. And as I mentioned earlier, there are many factors that affect hemodynamic. And depth of anesthesia is only one of them. But unless we monitor the depth of anesthesia, we really don't know whether with someone with higher blood pressure, is that because the patient did not receive an adequate anesthetic, or is it because the patient is inherently has hypertension? So that, again, points to the importance of measuring the anesthetic effects of the brain. So how does that help you when you measure the anesthetic of the brain? Well, one way to measure the anesthetic effect is what we call this bispectral index, which is basically a process EEG to help us to tell us where exactly we are when the patients are under anesthesia. Is the patient too light, too deep? And for example, this study shows that if you were to induce patient with Propofol and using the BIS to monitor where the patients are. Now again, a couple of things that really strikes me as far as this induction with Propofol and monitoring the anesthetic depth. So the red circle represents awake and the blue circles represent where the patient is asleep. Now, it is pretty consistent that below the BIS or about 70, most patients are asleep. About 65 to 70, you can see that with the exception of this odd one, most patients are asleep when you have a BIS of below about 65. Now, but when you were to measure the Propofol concentration, you can see that it is about 5-fold difference, right? From 2.5 mics per mil of Propofol, and this group here is up to 10 to 12 mils of micrograms of Propofol. So by even measuring the blood concentration is not a very predictive factor in terms of determining whether the patient is awake or asleep. But if you are using a bispectral index, pretty much 99.9% of patients sleep below the BIS of 65 or 70. So that is the value of monitoring, because when you are measuring propofol concentration, we are really monitoring the pharmacokinetic effect of the drugs, whereas bispectral index monitor the pharmacodynamic of the effect, which is very variable between patient population. So how does BIS help us to deliver TIVA more effectively? Well, in contrast to the inhalational anesthetic, we don't really have an end-tidal monitor, agent monitor for an intravenous anesthetic, so we can't really measure that. Again, we don't know, for example, if because propofol is delivered intravenously, if there's a king tube or disconnected tube, we really don't know until the patient probably shows signs of movement. So measuring this anesthetic effect has got significant advantage when you are providing a total intravenous anesthesia. So this slide shows you a pretty good correlation between the BIS and the propofol concentration, and also between the depth of anesthesia and where the patients are during the course of the anesthetic. So you can see that at induction the BIS goes down, and when the BIS goes down too deep, you can see this suppression ratio goes up. And what is the significance of that? Well, we don't really want to keep patient too deep. And when you have a very deep suppression, and that suggests that the patient is too deeply anesthetized, and studies have shown that if you have patient too deeply anesthetized, your incidence of postoperative cognitive dysfunction or delirium may potentially increase that incidence. So that is some advantages of using bispectral index. Now, as I mentioned earlier, when you have faced with a patient with hypertension, tachycardia, maybe sort of show signs of autonomic response, does it mean that the patient is light? Well, it may or it may not. And having a bispectral index monitor, it really helps you to basically focus on, what is my next management strategy approach? If you have a patient who are hypertensive tachycardic, the natural response is to increase my anesthetic depth. But that may or may not be the right thing to do. And if you have a bispectral index, if that bispectral index tells you that, well, the BIS is 65, 70, so in other words, the patient is light, that may be the appropriate thing to do is to deepen anesthesia. So if you have a high BIS value, then you consider increasing your hypnotic, increasing your analgesic. That is the appropriate management approach. Now, if you have on the contrary, have a low BIS value, so in other words, the pressure is high, tachycardia, and yes, the BIS value is in the 40s. And that shows you that, in fact, that hypertension and tachycardia is not related to inadequate anesthesia. And therefore, there are other reasons why a patient is hypertensive, tachycardic. Maybe they had, inadequate hydrations. They may have blood loss. They may have, inherent pain, for example. So that is a different approach that one should take. Instead of deepening the hypnotic aspect of the anesthetic, one may need to consider taking other actions, maybe use antihypertensive and others. So it does provide a great way to more accurately determine what is the right management strategy. Now, many studies have been published that looked at the effect of BIS on the use of anesthetic agent, in this case, the use of propofol. And on average, most studies shows that the use of anesthetic drug, in particular hypnotics, is reduced by between 25 to 30%. And that is pretty consistent. As you see here, a 2014 Cochrane meta-analysis, after analyzing a large number of studies, show that you can reduce the drug use by 23%. Now, I want to share with you in the next few slides a study that that I had the pleasure to conduct many years ago now, and really trying to determine what is the clinical utility of bispectral index when we give a propofol anesthetics. So it was a randomized double-blind control studies. We enrolled just over 300 patients. They are all to undergo general anesthesia with propofol L-fentanyl anesthetic. So in one group where we designated as a standard of care, so they titrate the anesthetic based on clinical signs, either autonomic clinical signs, blood pressure, heart rate, sweatiness, and the things that what we traditionally do. And then another group, we basically put on a bispectral index and have the anesthetic titrated based on the value of bispectral index. And we targeted the bispectral index value between 45 and 60 during the case. And towards the end of the case, we lightened the anesthesia to about 60 to 75, or base 15 minutes before expected emergence. So let's just take a look at what happens when we run this protocol. What outcome do we see? Well, first of all, as I showed you previously, we saw about a 23% reduction in propofol use because we tend to do over anesthetize our patient without the BIS monitoring, because we want to err on the side of caution and not to have patient awake. Therefore, we tend to run a deeper anesthetic. So with BIS monitoring, we can run a much more appropriate level of anesthetic, and therefore we see a reduction in propofol use. Another study by a box guy here, as you can see here, very similar design, and there are 120 adult ASA 1 and 2 patients undergoing ENT procedures. And they had a group that used propofol and a group that used sevoflurane. And again, one group standard of care, the other group with bispectral index. And what they found is also very, very similar to what we found in our clinical utility study. They found a reduction of propofol use of about just under 30%. And they also found that, in fact, these patients opening eyes at the end of the procedure is much quicker. And again, these are the two studies. They consistently found that they open eyes quicker, they respond to commands earlier, there are more patients can be extubated earlier, and more patients meet the PACU discharge criteria. So all points to an earlier recovery of the patients in the bispectral index monitored group. And when you compare these, the outcome, again, in our study, again, we found very similar. With bispectral index, you typically get about 3 to 4 minutes earlier recovery at the immediate post-operative period. And what is also interesting is that when you send a patient to recovery room, the nurses typically know which are the patients who were monitored with BIS, because they found that more patients could be discharged from PACU earlier, meet discharge criteria sooner if the patient had a bispectral index monitoring. And time to extubation was also significantly shorter, and the orientations on PACU arrival are also higher. 83% more patients were oriented when they arrive at PACU compared to those patients with standard of care without bispectral index monitoring. So when they come to recovery, as I said earlier, the nursing assess them to see which are the patients, how do they recover? Is it a good recovery? Is it excellent recovery? Or is that sort of fair, slow recovery? And again, it's no question that the nurses often can tell which are the patients who had monitored by BIS, because the recovery profile is significantly quicker, faster, better recovery when they were monitored with bispectral index. 16% faster than standard practice in a PACU discharge time. And this is important, especially in today's practice, where I'm not sure about your hospital. Certainly my hospital PACU is always full. And if we can get the patient out of PACU earlier, that means that we have less delay of patient coming from the operating room to PACU, and the cost of OR is very, very high. It's estimated to anywhere between $30 to $40 a minute. So imagine that if you have a full PACU, the patient can be transferred to PACU at the end of the procedure, you have a significant increase in the cost of the healthcare delivery. So all this will help in trying to get a patient out of recovery. Now, let's focus a little bit about post-op delirium, because this is something, as I mentioned earlier, is a significant concern. This study looked at elderly populations undergoing colorectal procedures, and one group that received standard of care using total intravenous anesthesia, and the other one, in addition to that, have a anesthetic titrated using BIS to between 40 and 60. And what they found is that those patients who were titrated, BIS titrated patients to a level of 40 to 60 have an average 38% decrease in incidence of post-operative delirium. So that is a significant decrease in patients with post-op delirium. And in fact, ERA Society recommends that the depth of anesthetic monitor should be applied to these procedures, from colorectal to pelvic, gastric, gastrointestinal, cystectomy, a variety of procedures we do every day. And ERA Society also have these guidelines in the 2018 that again demonstrate that there are different depths of anesthesia, and that we want to try to target appropriate depth of anesthesia, not too light, so to run the risk of awareness, at the same time not too deep, because you can potentially increase complications and post-op delirium, in particular when you run the patient especially deep when they demonstrate burst suppression. And there's again good study to correlate incidence of delirium and the duration of burst suppression. So now there are a number of important considerations when you are using bispectral index, and I think it's important to understand some of these considerations so that you are better educated when you are using bispectral index, and understand what the value that you see on the monitor, what does that mean? So number one, now EMG is electromyograph activity, and it's something that we see in our patients, especially those who do not receive a neuromuscular blocking drugs. And that EMG activity can interfere to a certain extent of the EEG signals. So if the patient who are not paralyzed with a neuromuscular blocking drugs, and on the monitor there is a indicator of what is the EMG activity, and often to get the best signal you want to see a very low EMG bar, and you want to see a very high signal quality index. So that is an important consideration. Now, there are some other medical devices that increase the BIS value. For example, we use warmer commonly in the operating room, pacemakers, and endoscopic shaver devices. So I think those, again, most of the time the monitor is shielded pretty well. But if you have some of the devices, you have to also take that into consideration. Now, a certain anesthetic, and I'll show you a graph a bit later on, for example, ketamine, because ketamine does not work as the traditional anesthetics such as inhalational agent or Propofol, where they act on GABA receptors. So that result in EEG activation. So in those scenario, the BIS does not give you an accurate number. Interestingly, there have a number of case reports that show that if you have hypoglycemia or hypovolemia or cardiac arrest situation, you tend to see the value of BIS tend to be lower. And that is maybe related to the fact that the EEG activity is obviously influenced by cardiac arrest situation, hypovolemia, ischemia, hypothermia, hypoglycemia. In fact, some case report actually show as a sort of teaching tools when they monitor the patients with BIS monitor, and they demonstrated, they show a sudden drop in the BIS, and when they measures patient's glucose level, they indeed find patient had hypoglycemic, and in some case reports show that in patient who had intraoperative stroke, EEG actually the BIS number comes down. So those are the things that it's actually very useful to know having a BIS number. And the other important thing to understand is that what the signal or the number you see on the EEG monitor is not the same at the same time as what the patient state is. There is a delay of about 10 to 20 seconds depending on the duration of your averaging of your data. And so what you see, the numbers up there, is what happened in probably 5-10 seconds, really a few seconds beforehand. And so one has to understand, and that's why a common question that people say is that, well, my BIS is 40 and the patient is moving, so this monitor is not telling me that the patient is asleep. Well, the reason it is the case is because the 40 number there is what happens a few seconds ago. And you'll find that once patient move and there's brain activation, and therefore the EEGs get activated, in the next few seconds you will see that BIS number suddenly jumps up from the 40 level. So those are, I think, important consideration, and one has to better understand is to understand the utility of bispectral index. Now, as I showed you earlier, that ketamine, and in this scenario, show that when ketamine 0.5 milligrams per kilo was administered, which is commonly done, especially for trying to reduce opioid requirement to improve postoperative pain management. And again, you can see a transient increase in the BIS response because ketamine does not act traditionally just like any other anesthetic acting on GABA receptor. It actually activates the central nervous system, and that's why you see an increase in the BIS response. So what can we summarize from today's webinar presentation? So first of all, enhanced recovery strategy, I hope showed you that can improve outcomes and reduce substantial costs without increasing the risk of complication. In fact, often reduces complication and mortality. Total intravenous anesthesia, I think, is a very good technique to optimize better recovery in a whole context of enhanced recovery pathway, where we focus on getting the patient back to normal as quickly as possible, to baseline as quickly as possible. So TIVA is a very attractive technique because of the number of advantages that we talked about earlier. Process EEG is recommended when using TIVA because we don't have a end-tidal agent monitor, just like inhalational agent. And in fact, even with end-tidal agent monitor, I find that BIS does help me to more appropriately manage the patient, select the right approach for managing autonomic response such as tachycardia, hypertension. And many studies have shown that using BIS can reduce the amount of Propofol, have quicker recovery. So all this taken together, I believe that using BIS monitoring in the context of enhanced recovery protocol, they are synergistic in the sense that, in fact, one helps the other. So monitoring the depth of anesthetic using BIS monitor achieve what enhanced recovery protocol is trying to achieve, which is to give the appropriate level of anesthetic and have the patient wake up as quickly as possible, and more importantly, have them recover during the recovery process so they are more clear-headed, they can get on with their recovery profile, do physical therapy. So all these are helping the success of enhanced recovery program. So with that, I'm going to conclude my presentation. I appreciate your joining us today. I'm going to hand it over to our esteemed moderator, Gary Bridges, who is going to monitor the Q&A session. Gary, thank you very much.
Outstanding, Dr. Gan. Thank you very much. Before we get into the question and answer session, I just want to remind us that there is continuing education credits for this activity, which has been approved for 1 contact hour for physicians, nurse anesthetists, nurses, and respiratory therapists. And you can acquire those credits by going to saxtesting.com/INIT. You will need to register on the test site, complete the evaluation form, and upon successful submission, you will be able to print your certificate of completion. Support for this activity has been provided by Medtronic. The on-demand version will be accredited for, again, physicians, nurses, and respiratory therapists. As well, a PDF of the slides will be available with the archive version. So now we'll go on to the questions, and before we get started, Dr. Gan, we have a really big fan of yours by the name of Anthony, and he just loves your presentations. So thank you for the feedback, Anthony. First question is from Lourdes, and the question is cognitive dysfunction more common after TIVA versus, I assume, general anesthesia? Any comments on that?
Sure, Gary. So that is a very good question. And again, this, so first of all, we know that post-operative cognitive dysfunction occurs fairly frequently, and we are starting to really recognize that fact. In the past, we really haven't monitored them closely, and I think, as with anything, the more vigilant we monitor them, we find that, well, they do indeed happen commonly. So the question is, how can we reduce that incidence? Well, the whole field here, again, is still fairly controversial, I would say. Now, but there are a few things that I think that a lot of study have shown or point towards that direction. Number one is that deeper anesthetic is associated with a higher incidence of post-operative delirium. In particular, when patients demonstrate burst suppression on their EEG. And there have been studies show that the longer the duration of burst suppression, the higher incidence of post-operative delirium. Now, with regards to comparing inhalational agent with total intravenous anesthesia, I showed you earlier there were 3 studies that show that the use of TIVA seems to be associated with a lower incidence of post-operative delirium and cognitive dysfunction. But again, about 40 to 60 may have a lower incidence of cognitive dysfunction or post-operative delirium compared to the standard of care, where the depth of anesthesia tend to be lower. Now, recently there was a large study called the Engager study that that showed that using biospectral index did not reduce the incidence of post-operative delirium. But interesting enough, the group that was monitored with BIS actually have a lower mortality rate. And they also showed that the group in the biospectral index group Again, the depth of anesthesia, as I said, the burst suppression seems to be also have a high incidence of post-operative delirium. So to answer your question, there is certainly some data that suggests that TIVA may lower the incidence of post-operative cognitive dysfunction compared to inhalational-based anesthetic.
Excellent. We have another question, Dr. Gann, from John. And he's asked, as you reduce the dose of Propofol, what is the effect on intraoperative awareness, and have you experienced any?
Again, another good question. Now, the whole concept of using bispectral index in total intravenous anesthesia is really trying to minimize the incidence of awareness. Now, when I use, in fact, whether it's total intravenous anesthesia or inhalation anesthesia, I use this for my patients. But for the intravenous anesthesia, that really is the only indicator of where the patients are, because we don't have an end tidal agent monitor, just like an inhalation agent. In my experience, when I use bispectral index during TIVA, I have not had a patient who tell me that he or she is aware when the BIS is appropriately managed at a level of between 40 and 60. Again, can it happen? You know, statistically probably can, but certainly it's extremely low. And I have been using Propofol for the last 30 years and BIS for the last 20 years, and I have not had a case of awareness under total intravenous anesthesia when the BIS is kept appropriately between 40 and 60.
Excellent. And I think also to add to that, Dr. Gann, is to not only just look at your value, but also to look at the quality of your EEG waveforms, because you had alluded to burst suppression, and that is also a really good indicator that maybe that you've gotten a little too deep in your anesthetic, and it gives you a good amount of feedback as far as functioning cognitively.
I couldn't agree with you more, Gary.
Okay, next question is from Sharon, who asks, do you use BIS in cases other than TIVA?
The answer is yes. I use BIS, in fact, for all my cases in the operating room under general anesthesia for a number of reasons. I think, first of all, I believe that even with inhalational anesthetic, it does help me to troubleshoot some of the cases that, as I mentioned earlier, with hypertension, tachycardia, where patients demonstrate signs of light anesthesia. Now, without BIS, one always assume that it's light anesthesia, but interestingly, when you have the BIS monitor on the patients, not all patients with hypertension and tachycardia are because of light anesthesia. There are other reasons. So using BIS allows me to troubleshoot what is the right management strategy in that context. Should I deepen anesthetic, or should I not deepen anesthetic and use other modality to treat the patient? So very simple. If you have hypertension, tachycardia, if the BIS value is high, I deepen anesthesia. That is the right approach. If, on the other hand, hypertension, tachycardia, BIS is low in the 40s, deepening anesthesia is not going to help you to reduce that blood pressure, to reduce the heart rate. Then you need to see what are the reasons the patient is hypertensive, the patient is tachycardic. So if the patient perhaps inadequately hydrated, then you may need to give some fluid. Or if the patient is, have hypertension, preoperative hypertension, and you may need to use an antihypertensive to treat that patient. So it does provide a great way to troubleshoot what is the right management strategy. And this is particularly important, in the context of, Gary, you practice in a cancer hospital, and I'm sure you do a variety of very large cancer operation where they have, major blood loss and things like that. And so this monitor can help you better troubleshoot when they have hyper and hypotension in particular. And so in hypotension situation, if a patient's blood pressure is 80 over 60, right? Now, typically the response, you're trying to reduce the amount of anesthetic, right? But is that the right thing to do? Without this monitor, you have no idea where the patient is at the hypnotic level. So with this monitor, if your BIS is low, yes, you can reduce the amount of anesthetic. But if BIS is already high, the patient is very lightly anesthetized. Lowering the anesthetic in that context of hypotension may not be the right thing to do. So I think that is where the value of monitoring the patient depth of sedation is.
Yeah, I agree with you, Dr. Gann. We also use the BIS monitors in addition outside of TIVA cases. And to your point exactly, it's an adjunct tool to enable anesthesia providers to tailor their anesthetic directly to the patient's needs. And I think you brought up some beautiful examples of hemodynamic responses, whether it's lightening or the depth of anesthetic, or whether it's another modality that we need to be looking at based on cognitive function. So that's great information. Another question from Mark is, we're interested in resources to implement TIVA, enhanced recovery after surgery, as well as BIS. Can you point, Mark, to any excellent resources as to where he would be able to retrieve and help be able to get resources to help start those types of programs?
Sure. There are many educational resources on the internet, and I can certainly point you to, there are a number of professional society that have a lot of resources with regards to launching enhanced recovery, organizing an enhanced recovery program. How does one go about it? What are the evidence or individual protocol? For example, I co-founded a society called American Society for Enhanced Recovery, and if you go to the American Society of Enhanced Recovery website, or ASERHQ, acerhq.org, there's a lot of information there about enhanced recovery. There are sample protocols. There are guides to help you. How do I start an enhanced recovery program? So similarly, the European Society called the ERA Society has a lot of resource information. In fact, if you're an anesthesiologist or a nurse anesthetist, ASA has a perioperative surgical home website, a very comprehensive resource information that you can get. ANA, I believe, and Gary can speak greater to that, because Gary, you are the president of ANA, and I know that ANA has one of the major focus is to help practitioner how to do enhanced recovery, and I'm sure ANA website will also have resources. So there are many resources out there, and again, if you need any resource, I'm happy to, you can contact me. I can point you to specific resources. Gary, I don't know if you have some additional things to add.
Yeah, definitely. Even with the AANA, we try to collaborate with as many of the organizations as well as yourself, Dr. Gann, with trying to not only of how to perform the techniques, but exactly what addressing the question is how do you get started within your facility, and that actually brings us to the final question here, which I think is Julie asked, who would you approach about starting a program like this in your facility, which I think is the $1 million question, pardon the pun.
Yes, I think that is a very good question. I think, first of all, again, I can, talk for an hour what the strategies are, but the key really is to kind of get a team together. I don't know, Julie, what your specialty is, but if you need really to get the key players, and anesthesiologists, you need to get a surgeon champion, You need to get a nurse champion. You ideally need to get your administrator on board, either a CEO or CFO or COO or CMO to get on board. Then you can get the team together, and then you can start to move to the next step. Most critical thing is to get the team together, get the protocol together, and then to start implementing it.
Yeah, and I'll add to that, Dr. Gan, and I think this is, you and I speak about this stuff all the time, and what resonates with, whether that be a hospital administrator, one of the first questions I usually ask people is how many of you are not allowed to use IV acetaminophen or Sugamadex or liposomal bupivacaine? Why is it not on your formulary? And the first response is yes, I can't use it. And the second, the rationale is because it costs too much, which is completely the wrong way to be approaching sort of the economic impact. And I think having some of those discussions with particularly administrators or pharmacy administration is that you can't look at direct acquisition cost. Incorporating these agents and the implementation of BIS technology is what allows you to individualize your anesthetic, first of all, thanks to, BIS monitoring, but also you're able to achieve extraordinary outcomes, which you've summarized throughout this talk today with the economic impact when you get high quality and outstanding outcomes by using TIVA as well as complementing that with BIS technology. You look at, for example, you present on some of the GI surgeries, and with the cost of even a single incidence of postoperative ileus has ranged somewhere between $10,250 to $11,500 just to manage a postoperative ileus. And through TIVA strategies with BIS technology, you're able to reduce those types of untoward outcomes significantly. So with that, we are at the end. I want to thank everybody for their participation and their attendance today.
Thank you again, Gary.
Yes, Dr. Gan and Gary, this is a fantastic learning experience, and we're grateful for your expertise and for sharing all your knowledge and excitement in this very important topic. And I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.